Hi everyone. Today I will be presenting a video analysis of a person running in the frontal plane. I will analyze 3 frames of the video, then discuss the anatomy involved as well as a relevant joint-related injury, going into depth on the etiology, pathology, and repercussions of this injury. I have chosen this task because as a physiotherapy student, being able to understand the anatomy, etiology, pathology of running-related injuries will enable me to deliver effective patient care. Additionally, the task was chosen as it explores the importance of the biomechanical aspect of running. 3 phases in a running gait will be analyzed. The first is the initial contact, then the mid stance, and then the takeoff phase. There are 3 planes of motion. These are imaginary, flat surfaces that split the body into different sections to describe movement. There is the sagittal plane, frontal, which is also known as the coronal plane, and the transverse plane. The frames used in this presentation are taken in the frontal plane. This can be particularly helpful in observing instability in runners, which is done through comparing the sideways movement throughout each stride. This information can be used to identify different strengths and weaknesses runners have. For example, excessive hip abduction can indicate weaker hips and ab muscles. This is a body segment that I will track throughout the frames. There are 2 other segments that I will track. These are the lower and upper extremities. I will track the upper extremities, which is the arms from shoulder to fingers, in running as they move in a pattern throughout the phases in a runner's gait. Furthermore, the focus is on the lower extremities and more specifically, the movement related to ankle joint movement. This frame, taken from Amy May's YouTube video, Running Gait Analysis on the Sagittal Plane, depicts a person running on a treadmill in the frontal plane from behind the runner. This is the mid-stance section of the running gait. The frame depicts the right foot in contact with the ground in extension. The left leg is in flexion with the foot in plantar flexion. In this part of the stride, the runner has already transferred force onto the right leg and is pushing through, utilizing the hamstrings, gastrocnemius, soleus, and gluteus maximus muscles. In this frame, the pelvis appears to be in a neutral position. This means the right and left lateral points of the hips are in the same position, which can be seen in this frame as the hip area is level. Secondly, the pubic bone and anterior superior iliac spine must be in the same plane. This is harder to tell from a frontal view and must be observed from a sagittal plane. A correlation analysis conducted by Ozan, Sever et al. found that there is a high interrelation between running kinematics and hip strength. The researchers also outline the importance of hip strengthening in runners to fix incorrect running kinematics. This frame depicts the subject pushing through the stride with their leg. The right leg is in a small amount of flexion of the tibia, and there is also slight flexion of the femur. There is also a small amount of flexion of the tibia in the left leg, and the foot is in plantar flexion. This is important to note as during the final push off the calf muscles, plantar flex the foot to help drive forward the runner. A running technique used by professional athletes is swinging their arms back and forth. With correct arm movement, foot placement can be improved. In this frame, the runner has a small amount of flexion in each arm and appears to be moving them back and forth. If her arm were in a greater degree of flexion and elbows more posterior with each swing back and come less anteriorly on the swing forward, her foot placement would be naturally under her center of gravity. This is important for several reasons, outlined in a systematic review with meta-analysis, Effects of Foot Striking Techniques on Running Biometrics by Zilan Zhu et al. This found that a rear foot strike increases the risk of knee and patellofemoral injury, while forefoot strikes increase the risk of ankle joint and Achilles tendon injuries. This demonstrates the importance of a center of gravity landing point, which, as discussed above, can be characterized by the arm movement during running. The last frame shows the subject landing, known as the initial contact. The right ankle is anterior to its knee, and the knee is anterior to the hip. The left foot is in a small amount of plantar flexion. The right foot also appears to be in slight supination. This is important to note when considering the biomechanics of this runner's gait, because in studies such as the case-controlled study by Artur Perez et al. That looks at the association between foot posture index and running-related injuries, showed that higher supination in the foot is associated with 78.6 times higher risk of injury than a neutral position. However, it must be noted that this degree of supination is not as severe as the levels referred to in this study. The running-related injury investigated today is ankle sprains. There are several ligaments involved in an ankle sprain. These complex ligaments allow for stabilized ankle movement. On the lateral side of the ankle, connecting to the lateral malleolus of the fibula, is three important ligaments. There is the anterior talofibular ligament, also known as the ATFL, which originates on the lateral anterior side of the lateral malleolus and inserts onto the anterior of the talus. There is also the calcaneofibular ligament, also known as CFL, the CFL ligament, which originates on the inferior lateral malleolus, then inserts onto the lateral side of the calcaneus. The last lateral ligament is the posterior talofibular ligament, also known as the PTFL, which also originates on the lateral malleolus, then inserts onto the superior side of the talus. A systematic review with meta-analysis by Farzin Halabichi and Mohammed Hasibi found that lateral ankle ligaments are involved in about 85% of ankle sprains. Furthermore, of all ankle sprains, 65% of cases involve the isolated injury of the ATFL, and in 20%, both the ATFL and CFL exist. The last 15% of total sprained ankles involve medial and syndesmotic sprains. This demonstrates the high amount of ATFL injuries. In most cases, the ATFL ruptures first, then is followed by the CFL. The PTFL and CFL isolated ruptures can happen, but are extremely rare. Additionally, the PTFL almost always ruptures after ankle dislocation. The medial side of the ankle joint also has a series of 4 complex ligaments known as the deltoid ligaments. These 4 ligaments are the posterior tibio-talar ligament, which originates at the medial malleolus of the tibia and inserts at the posterior and medial surface of the talus. There is also the anterior tibio-talar ligament, which also originates at the medial malleolus, but on the anterior collicus of the malleolus. This ligament then inserts at the anterior side of the medial talar surface. Thirdly, there is the tibio-navicular ligament, which originates from the anterior collicus of the medial malleolus and inserts at the dorso-medial surface of the navicular bone. Finally, there is the tibio-calcaneus ligament, which originates at the posterior and inferior surface of the medial malleolus and inserts at the calcaneus. Ruptures of the deltoid ligament are rare, as it is quite a strong series of ligament. Another ligament related to ankle sprains is the distal tibiofibular syndesmosis, which connects the tibia to the fibula. The mechanism of injury is often external rotation of the foot, excessive dorsiflexion, and eversion of the talus. Around 10% of ankle sprains are accounted to distal tibiofibular syndesmosis ligament sprains. Okay. There are 2 main types of ankle injuries. There is an inversion injury and an eversion injury, also known as a lateral ankle sprain and a medial ankle sprain. Inversion injuries are the most common and occur when the foot is inverted in plantar flexion and abduction, which is known as the mechanism of injury for a sprained ankle. This type of ankle injury most commonly causes the ATFL to tear. Damage to the CFL is the second most likely to occur, and the PTFL damage being more rare. A high ankle sprain is the more uncommon type of ankle injury and occurs with a sudden twisting motion where the distal tibiofibular syndesmosis ligament is damaged. A systematic review by Pia Jungmann et al. Found that ankle sprains account for around 16 to 40% of sport-related injuries, with basketball and soccer players being the highest risk group. Actions such as a sudden change in movement while playing basketball or landing on an uneven surface after jumping are both examples of high-risk actions that can make someone more likely to sprain their ankle. In the 3 frames taken from the YouTube video, there are several possible ways in which the runner could sprain their ankle. In frame 2, where the right foot is about to come into contact with the ground, the weight is about to be distributed onto that leg, and more specifically, the ankle. If the runner made a turn to the right after the foot has been planted, the ankle may invert. This is due to the body changing direction while the foot stays planted. Another example of a possible way that the runner could sprain the ankle, but as an eversion injury, is if the runner experienced an impact at the knee of the leg planted from the lateral side, which would cause the ankle to go into eversion, potentially damaging the deltoid ligaments. A descriptive epidemiological study by Thomas Kopeck et al. Found that this mechanism of injury is most experienced by soccer players. Okay. A systematic review by Tricia Hubbard and Eric Wilkstrom found that 75% of initial lateral ankle sprains led to repetitive sprains and chronic symptoms. Additionally, a longitudinal study into the predictive factors of recovery after an acute ankle sprain by Philip Terrier et al. Found that nearly half of participants with lateral ankle sprains did not recover after 7 months. These two studies demonstrate the importance of an effective recovery. A systematic review by Tricia Hubbard and Charlie Hicks found that predictive factors of a successful recovery was effective injury management, being rest, ice, compression, elevation, and functional rehabilitation. The study further discusses how often the injury must be assessed on an individual basis. Thank you for listening to my presentation.